Good afternoon, everyone, and thank you for joining today's Pneumonia Knockout Readmissions Series 1, using AHRQ and Aspire tool to reduce pneumonia readmissions. We would like for these meetings to be very interactive, so we are anticipating that you will be highly engaged in today's session. We're encouraging you to ask questions and share information throughout the webinar today utilizing your chat and question panel. To ensure you can chat to the entire audience, and to the organizers and panelists, please chat in now your name, how many people are in the room with you, and where you're dialed in from. Please select, if you can, to the entire audience, otherwise select to the organizers and panelists. We will keep all lines muted to cut down on feedback, distractions, and echoing. While you're testing your chat function, we'd like to go over the logistics for today's session. As I said before, all lines are currently muted and in listen-only mode. During Q&A, you may ask a question or make a comment by entering questions and comments into the chat panel or into the question panel. You can also raise your hand by raising your hand, which is located in the left-hand side of the grab tab on your control panel, and we can unmute you. Please tell us your name and your organization when speaking. And remember that you do need to have your PIN entered, your unique ID PIN, which is in your audio panel, so that we can unmute you. The session is being recorded and will be made available on the North Carolina Quality Center website and through email notifications shortly after the conclusion of today's session. Facilitating for you today is Karen Southard, VP of Quality and Clinical Performance Improvement of the North Carolina Healthcare Association. And presenting for you today is Dr. Amy Boutwell, founder of the Collaborative Healthcare Strategy. At this time, I would like to turn things over to Karen.
Thank you, Sarah. I appreciate it. And welcome to everyone. I see our lines are steadily still growing. We're at 72. In attendance right now, and I'm sure there's many more that's huddled in a room listening to this. So without further ado, let us get started. Amy, can you advance the slide to slide 3, the knockout pneumonia team, please? So I just want to welcome Dr. Amy Boutwell as she joins North Carolina Hospital as we are continuing to work on our knockout pneumonia readmissions. We have a year-long collaborative that's been planned with Dr. Boutwell. She is well renowned for her work with IHI and the STAR program, and I have known Dr. Boutwell for well over 8 years and working together as a pioneer in care transitions and really better understanding and utilizing your data to drive success. She definitely has a lot of experience under her belt, and I've personally worked with her both with CMS as well as working on the, now is the Aspire tool, but at the time was the AHRQ Medicaid readmission tool, which we piloted in South Carolina together and had really good success. So I think that we're in for a great treat. This is going to be a series of webinars that will accumulate into an in-person learning session in October with Dr. Boutwell at our Quality Symposium. So without further ado, let me turn this over to Dr. Amy Boutwell, and let's get started with our webinar session 1.
Okay.
Dr. Boutwell?
Great. Thanks so much, Karen. It's really great to be here, and thanks to you all for taking time to join us today. As we're kind of kicking off this year-long webinar series, you will have an opportunity to cover a lot of strategies to help you reduce your pneumonia readmissions and really to integrate your commitment to reducing pneumonia readmissions with your overall readmission reduction efforts as well. So I'm really looking forward to this important initiative and helping you advance your work. Now, my colleagues at the Knockout Pneumonia team are telling me that you can still see my my layout screen, and I'm seeing presentation view. So I'll just ask the team if you want to chat me any recommendations on how to make this look better, or if you want to take it over, that's perfectly fine with me. I'll just take my cues from you. Okay, perfect. So do you want to advance? Are you going to advance on your end?
Amy, we'll go ahead and give you keyboard control so that you can advance.
Okay, perfect. Thank you so much for helping me fix that. Okay, great. So should I be able to advance? There we go. Good. Okay, great. So I'll catch up with myself. Apologies, everyone. Okay, so here is the outline of our scheduled dates for our 1-hour webinar series. Roughly every month, we're skipping a summer month for a little breather, and then we'll get together in October in person, as Karen said. So hopefully you can take these dates down, and all webinars are 2 to 3 in the afternoon, and we will keep a steady pace of work in progress going together over 2018, which I'm really looking forward to. The purpose of the Knockout Pneumonia Readmission Series is, of course, we know that you're working on reducing pneumonia mortality as well as pneumonia readmissions. I come to you to really help strengthen, accelerate, and make progress on that pneumonia readmission part. And so what we're going to do is focus on connecting some core concepts that I have found tried and true and highly reliable to sharing concepts, but moving very quickly from concepts into action steps. We'll focus on high leverage strategies to reduce readmissions and focus on implementation coaching as we go through the webinar. So today I have a lot of information to share with you, but as Sarah mentioned at the beginning of the webinar, in general, we would love you to come ready to talk about your readmitted patients, your readmission strategies, what you're learning about the challenges and the successes of reducing readmissions for this important patient population. To that end, I really recommend that the best use of your time is to use these hour-long slots that we have together to actively advance your pneumonia readmission work. This is not necessarily meant to be just an educational series. I know that many of you know a lot about readmissions. Many of you know a lot about pneumonia, of course, as a clinical condition. This is meant to be much more tactical and action-oriented. So I encourage you in the future, moving into April and beyond, come with questions and challenges. Come with patient stories, with your data, with your ideas for improvement to really kick the tires. Is this high leverage? Has this worked elsewhere? That's really how you can leverage what I bring to you during our time together. Another great idea would be to invite your cross-continuum partners to attend. And I know from our initial work with the Knockout Pneumonia team that some of you do have cross-continuum teams in place, and some of you are thinking about who you might need to collaborate with more. And I'll help you think about what partners have you not yet thought about reaching out to. And so this webinar series, as we go through the year, you might want to use the webinar series as a tool for engagement to invite partners either virtually from their own office or with you in the conference room to listen to these webinars together and move into action based on the ideas that we share. And then email us, as I know Trish and Karen keep very close touch with you. Email us with questions or issues, and we can take those questions and issues and use them to program into the next webinar. And in that way, we can stay in touch and right on pace with how quickly you're moving, the challenges you have, the issues you'd like to discuss. And that's really what my commitment is to you as we have this monthly time together moving forward. So today, we are going to focus on two things that I can't imagine any successful team would be able to get success without these two steps, which is knowing your data, commanding a working knowledge of your data. It's so important. And really understanding the root causes of pneumonia readmissions. So I'll get into it to describe to you why I think these two things for today are the right place for you to start. So to get started, I don't know if you guys did use the chat when Sarah invited you to. I didn't see it, but that's okay. If you did use the chat, please do get back to your computer keyboard, and I'm going to ask you some questions that I either encourage you to write down or discuss if you're in a room with others, or to chat in with us. So here are some questions that by April, every knockout pneumonia readmission team should be able to answer. Question 1, what is your hospital's current all-cause readmission rate? And you'll note that when you're working with me, I define all-cause as adult, non-OB. And, you know, there are many ways of measuring and defining readmissions, but we just kind of keep it simple. For this purpose, when I say all-cause, it's adult patients who are not here to deliver a baby. Okay, so what's your hospital's current all-cause readmission rate? So this is the overall readmission rate, not the pneumonia readmission rate. Do you know the answer? For those of you, I know that we have a lot of systems in North Carolina, and I know that some of you are leading system-wide efforts. So I too work with a lot of system leaders, and I know that system leaders focus on the system. And I will ask you as we move forward to know not only your system's readmission rate, but the readmission rate of each of your sister hospitals as well, because I don't need to tell you your downtown teaching larger community hospitals are very different from your suburban and your rural community hospitals, and the readmission rate and the readmission patterns, even for pneumonia, may end up being meaningfully different, and we don't want to miss the opportunity to understand those differences by only looking at system level data. Okay, so hopefully you know the answer to your hospital's all-cause readmission rate. Next question then is, what is your hospital's pneumonia readmission rate? So it can be very important and helpful to know we are already committed to working on knocking out pneumonia readmissions. To what extent are pneumonia readmissions tracking higher than your hospital readmission rate or at the same as your hospital readmission rate? It's probably not lower, but it's really good as a base understanding for you as a knockout pneumonia readmission champion at your hospital to be able to say, our hospital's overall readmission rate is X and our hospital's pneumonia readmission rate is Y. So moving on to the next question is, we're committed to reducing pneumonia readmissions. Do you feel like you really know the root causes of pneumonia readmissions? And a question for us to think about and discuss during our time today is, how do you identify the root causes of readmissions? What strategies are you using? And I have a strategy that I'd like to encourage you to test and see if it's helpful for yourself. Next question is, what's your hospital's overall readmission reduction goal? And of course, the companion is, what's your hospital's pneumonia readmission reduction goal? Now, the reason why I put this on is not just to be simplistic. Many hospitals these days are setting readmission reduction goals at the board level, or certainly at the director of quality or another executive level. So you may have a hospital-wide and those of you in systems, a system-wide readmission reduction goal. That goal may be related to Medicare readmission penalties. It may be related to other risk-based contracts that you have. It may be related to a quality strategy that you lead with, but I'm betting that your hospital's readmission reduction goal is not necessarily the exact same thing as the knockout pneumonia readmission goal that we share together. I know you've already committed to and been oriented to the reducing pneumonia readmissions by 5%, and that's the goal of the collaborative. And I would just again ask you, is that your specific hospital's pneumonia readmission reduction goal? Or have you looked at your data and you've decided that you have something more specific, more targeted in the spirit of our collective aim, but maybe you've articulated a specific other aim? And the reason why this is, of course, important is because we want to help you reach your goal, and whatever your goal is, it would be very helpful for us to know that. Okay, a final set of questions. Based on your current readmission rate, your understanding of root causes, your specific readmission reduction goal, what strategies are you testing and working with to reduce pneumonia readmissions. So of course, I don't see any chat here, probably because I can't. But just to orient you to the future, we will have a vibrant use of chat in the future. So these are the types of questions that I'll bring to you, and we'll wait to make sure that we're able to discuss and review everybody's answers in the future. But we won't do that today while we're just getting started. And then with regard to the strategies, because I've read some of the prep notes and the orienting materials to what some of you are working with, do you consider these targeted strategies? And targeted in this case, I would say, is do your strategies to reduce pneumonia readmissions address the root causes of readmissions in your patients with pneumonia? And so again, this is all food for thought, questions to come back to in the future. So right now, oops, I'm gonna just skip over these 3 questions here since we don't have a lot of chat going on. Okay, so right now I'd like to orient you to the foundational core curriculum of the Aspire Guide. So you'll hear me reference Aspire Tools, the Aspire Guide, and this is a literal book. It's about 80 pages in 6 chapters, and it's freely available on the Agency for Healthcare Research and Quality's website. I hope you will have asked someone, at least on your team, to download it and flip through it and orient yourself to the material in the Aspire Guide. You will be able to move as quickly as you want to through the material of the Aspire Guide, and that will allow us to keep pace with you as to what you most need in order to reduce your pneumonia readmissions and hit your goal. So the Aspire Guide was born out of a really interesting and important question that the Agency for Healthcare Research and Quality asked about 6 years ago. They noted that, of course, the Medicare readmission penalties were stimulating a greater and greater focus on reducing readmissions in the field, and that, of course, we were all naturally focused on the Medicare patients with those targeted conditions. And by all means, our Medicare patients with pneumonia are exactly that important group. The Agency for Healthcare Research and Quality, AHRQ, asked my team to do some work to understand how we need to adapt or expand or otherwise modify our readmission reduction strategies that we've learned about from the geriatric health services research. So that might be the care transitions model or Project Boost, for example. And how do we need to adapt or modify those strategies to better meet the needs of the Medicaid population? And one thing that we learned that all of you clinicians will relate to is we learned that it's not a Medicare strategy or a Medicaid strategy. It's what you kind of see here in the title, which is it's designing and delivering a whole person strategy, a payer non-specific. What we really want to do is we want to identify high-risk patients. We want to effectively identify their needs and their readmission risks. And we want to go about offering better care and better services and supports to meet their needs in order to reduce readmissions. So the Aspire Guide, while it has Medicaid in its genesis, that's what we were kind of funded for and what we focused on, really it's much more of an all-payer approach in terms of strategies to reduce readmissions in general. So you'll see, I'll reference some tools. The tools are downloadable in a PDF form, but also in live documents, whether those are PowerPoints or Excel or Word documents. You can download them, you can put your logo on them, you can edit them. They are completely open source for you to use or not use as you find helpful. If there's one thing I've learned about tools in readmission reduction, it's that no team takes a tool straight off the internet and uses it as is. Everybody always likes to tweak it, and I say no problem. You do what's going to work for you. There's also a 6-part webinar series. We won't go into depth in walking through the parts of the Aspire Guide necessarily in the same way that this 6-part webinar series takes an hour for each chapter and really goes through some of the detailed content in each chapter. Since we're focused on pneumonia readmissions, we're going to spend our time applying the concepts from Aspire to pneumonia readmissions specifically. But again, if you find this materials helpful, you might want to also find time to listen to the webinar series. Okay, so why do we call it Aspire? Just very quickly, this is a driver diagram, and it's one of the most powerful strategic tools that I've worked with in the past 10 years. It orients us to what is our goal, what are the major ways or strategies through which we will achieve that goal. Those are the primary drivers in the gray. And what are the specific steps that we need to take? Those are the secondary drivers in the Aspire acronym here. So what you can see is that the Aspire framework or the Aspire model is really an acronym for this, the universal strategy that we apply, in this case, to reducing pneumonia readmissions. So the ASPIRE stands for various steps in the process. We'll go through those during our time together over the next couple months. But really what I wanted to orient you to today is one of the major differentiators between the Aspire framework and other care transition models, which is in the primary, represented here in the primary drivers. We noticed that many hospitals pick up a care transitions model and apply it generically to a high-risk population. If you will, they move straight to deliver, and they move straight to the E part of deliver. They move straight to saying, we're going to stand up a program that looks like this, that, and the other thing and has the following services. And they run the program and they either do or do not get results. But if they do not get results, they end up scratching their heads and saying, gosh, our staff's so talented and they're working so hard, we just don't understand why we're not getting results. And it's been our observation over so many years of field work and looking at successful hospitals and hospitals that are working hard but don't yet have success. The delta appears to be in this first primary driver, which is design. Have they understood what they're doing, what their data shows them? Have they aligned what's going on internally and the resources that are available externally? And have they developed a multifaceted, data-informed portfolio of strategies to achieve their aim? Whether that aim is to reduce Medicare penalties, whether it's to reduce readmissions for pneumonia, it's the design and analysis part appears to distinguish successful hospitals from really hardworking but not yet successful hospitals. So that's why today we're starting with the analysis part. So again, just a note that hospitals with hospital-wide readmission reduction results, there are more and more every year, I'm happy to say. There's still a distinct and proud group, I would also say. What distinguishes hospitals that have gotten the results that they wish to see with regard to reducing readmissions appears to be the following. Number one is hospitals with hospital-wide results, they know their data. They analyze it, they track it, they trend it, they post it, they share it. Yes, the executives know it, the board knows it, the managers know it, and the staff knows it, and their partners know it. And so data is liberated. When you see a hospital that is doing well with readmission reduction, and really it goes the same for any quality improvement initiative, but in particular for readmissions, data is not secret. If we're not doing well, then we post that number and we commit out loud, just like we all have, that we are committed to improving this number, and we won't stop until we get the results that we aim to achieve. So it's very much a culture, a manifest culture. So ask yourself, is that how we're using our data? Do we know our data? Have we shared our data? Do my staff on the care transitions team or in the care management department or in hospital medicine or whatever the case may be, do they know what the readmission rates are and what our goals are? Number two is they take a broad concept of readmission risk. It's not just that the patient has pneumonia, it's that the patient has pneumonia and they're going to a skilled nursing facility, or that they have pneumonia and they're socially isolated, or that they have pneumonia and they just lost their job and their insurance is now in flux. You know, these are the elements of risk. It's the human element of risk, in addition to the clinical element of risk, that we need to incorporate. But we balance not just the diagnosis and the management of the disease, of course, with the person and the context of the person's life. They have a balanced and multifaceted portfolio of strategies. They make improvements in the hospital. They actively collaborate with receiving providers across care settings, and they deliver enhanced services to mitigate readmission risk over time. They do all three of those things, not just one or the other. You've heard many times before, readmission reduction is not about a silver bullet, and that's where this multifaceted portfolio of strategies has become apparent to me as I study successful hospitals. And increasingly, we're using technology to make this work better, faster, automated, more reliable, to bring data to the point of care, to identify patients in real time, to track and trend and follow patient needs and close the loops, et cetera. So if you have technologies to bring to bear, then your knockout pneumonia work would definitely benefit from it. So let's move into some data hot off the press. Thanks to the NCHA Pneumonia Knockout team. This is incredible work that they did in short order to get us some North Carolina Allpayer Pneumonia readmission analyses. Now, I know you've all seen some readmission analyses, so I know you're familiar with data. What we're going to go through here in the next about 10 slides really quickly. And of course, you'll be able to go back to this as you, if you have more questions or want to kind of look closer. But the NCHA team used the inpatient discharge database to look at all-cause, all-payer pneumonia readmissions for adults. Okay, again, adult non-OB, that's my basic inclusion-exclusion criteria. The year was 2016, and probably not much, has changed necessarily in 2017. So I think 2016 is enough at least to paint us a picture. So back in 2016, what you can see here is there were 723,000 discharges overall, 18,000 of which were coded as a primary discharge diagnosis of pneumonia. So that's between 2 and 3% of all discharges. Why do I emphasize that? You'll remember one of the questions I asked in kind of the thought discussion earlier is how many pneumonia discharges do you have on a daily basis? It's probably 2% of your discharges. It might be 0, 1, 2, 3, 4, or 5 discharges per day. It's really helpful to get a sense of the magnitude of the volume of the potential target population that we're seeking to serve, which is why I point this out. Now, there were 108,000 readmissions of any sort in 2016, and there were about 3,000 pneumonia readmissions. So it's a little bit higher percentage of readmissions than discharges, and again, that's partly why we're focused here. The overall North Carolina all-adult all-payer readmission rate was 15%, and for pneumonia, it's 16%. Again, these are just kind of key stats that as you talk about why are we focused on pneumonia readmissions and what are the North Carolina stats the best we know, these are some basic facts and figures for you. Really great visual here of the trending of pneumonia readmissions over 2016. So this is just month by month pneumonia readmissions in the red. And actually, I think it's compelling for us all to know and that even over the 1 year period of 2016, pneumonia readmissions trended upward by 13%. So we're not only looking to reduce pneumonia readmissions, but we need to bend the trend of what was happening there in 2016. And this is in a context of the blue line where overall readmission rates in North Carolina more or less stable during the same period. So again, that's what brings us together, but I thought the visual was really helpful. This is a trend line by payer. So I know that part of the official measure of the campaign is the CMS measure. There are really good reasons for that. But in general, what you can see is whether we're looking at Medicare patients with pneumonia, Medicaid patients with pneumonia in the red, or commercially insured patients, pneumonia patients in the green, all pneumonia readmissions were going up for all payers across 2016. So although the measured goal might be Medicare, and again, that's a very important focus area, I wanted to make sure you knew that all payer pneumonia readmission rates were trending up as well. So this is a really great analysis that the team did. We ran the top 10 discharge diagnoses that contributed to the most readmissions in North Carolina. And what you can see is the top 10 list for Medicare, Medicaid, commercially insured patients, and overall, okay? There's another column, other, which was of small numbers, so I left it off. You can see, of course, yes, pneumonia is a top reason for readmissions, causing the most readmissions in North Carolina across the board. And I know that in some of your prior work, you've been talking about the relationship between this important patient population of pneumonia patients, and of course, they have comorbidities and co-occurring illnesses like sepsis, COPD, heart failure, and so I thought this would be helpful for you to put the primary discharge diagnosis of pneumonia in context with these other very active conditions that our patients have at the same time. And sometimes it can be hard to know, is this patient going out the door as a primary pneumonia, or are they going out the door as a sepsis or a COPD? Again, sometimes it's not easy at the bedside. So I think being aware of the general top 10 list can be very informative as we implement our work. Here's a couple breakouts focusing just on our pneumonia readmissions. And we're going to first look at pneumonia readmissions by age. So, yep, we're focused on Medicare, and you can see that the adults age 65 to 84, they have the most pneumonia discharges. That's in the red column. They also have the most pneumonia readmissions following those discharges. That's in the blue bar for that age group. And that age group does have the highest pneumonia readmission rate at 17.5%. I specifically broke out the age group immediately before and after that 65 to 84 group because it is not very well known or appreciated that readmission risk does not just go up continually with age. So readmission risk goes up with age, but it is not continuous at the extremes of age. So I just wanted to point out, I see this in national and state level data all the time, which is why I wanted to just bring it to your attention. Over a certain age, you know, the readmission risk is not as high. And again, just food for thought and to broaden your knowledge base there. The other point I wanted to make with age, though, is that we often only look for people over age 65. And as you can see on this graph, that would be a mistake. We need to be worried about our middle-aged adults as well, who are in the hospital with pneumonia, especially the 45 to 64 age group. So, so you can see that for all intents and purposes, adults age 45 to 64, their readmission rate is 16%, which is exactly the same as the pneumonia readmission rate for North Carolina, which is 16%. And so, food for thought there. Readmissions by payer, we know that Medicare has the most pneumonia discharges. You can see that very clearly here in the red column, and that they also have the most Medicare, the most pneumonia readmissions following a discharge. The pneumonia readmission rates for Medicare in this data set was 17.2%. But here again, food for thought, the pneumonia readmission rate for Medicaid adults, 18.3%. much smaller volumes, as you can clearly see on the column chart here. But when we look at the readmission rates, very compelling. So, so when you're looking for your target population, probably being payer non-specific is practical. Clinicians don't really like payer-specific initiatives, and so I think the data would substantiate that at least Medicare or Medicaid makes sense for a target population. The commercial pneumonia insurance, the commercially insured pneumonia readmission rate is 11%, so it is substantially lower than average, which I just bring to your attention for your consideration.
Hey, Amy, I have a chatting question.
Oh, okay. I can't see.
Does the readmission rate include primary and secondary diagnosis, or just the primary diagnosis?
We're doing primary diagnosis here. Thank you for the question. Yep, primary diagnosis. And so, so we can talk about that, but that was to keep it very straightforward and also consistent with the way kind of state and national data, readmission data are run. Thanks, Karen. So quickly, there's been a big and important emphasis over the past 2 years through the Hospital Innovation Network and the CMS Partnership for Patients to make sure we're always looking at our data by race, ethnicity, and language wherever possible. And so we asked the team to stratify the data here by pneumonia readmission rates by race. We all know that that this data is only as good as it's accurately coded, but this is what the results are. We see that the readmission rates for patients of Caucasian race, 15.5%, and of Black or African American race was 17.8%. So there clearly is a disparity here for us to be aware of. And I know that some of you, my colleagues at Novant, have specifically taken a deep dive into closing the gap between pneumonia readmission rates for African American patients and for Caucasian patients. And so that's some really great leading work that we can learn from and pay attention to as we go through the collaborative. Another way of looking at the at pneumonia readmissions is by discharge disposition. So this is very practical. We're going to think, where is our patient? Once we identify a patient with pneumonia, we are going to think, what do we need to do in order to mitigate that patient's readmission, risk of readmission? Well, typically on the floors and during rounds and during patient and family discussions, typically when we're worried about a patient, we work like the Dickens to get them to accept our recommendation to go to have post-acute care skilled nursing services, whether that's in a SNF or at home with home care. And once the patient and their family say yes to that, what do we always think? We kind of wipe our brow and say, phew, that is going to be a strong discharge plan, right? Now, while that is true, this is what the data also shows, okay? It's kind of a yes and type of a phenomenon. The yes and, which is counterintuitive until you see the data for yourself, is we actually need to take the fact that the patient has ongoing skilled care needs and has actually been discharged into post-acute care as our marker that this is now the highest risk pneumonia patient you have discharged today. Yes, you have discharged them into skilled care. That is a good thing. But it's your marker to say, and now what else are we going to do? Because whether they're going home with home health care or they're going to a SNF, they have a 20 or 22% readmission rate, which is much, much higher than our 16% overall pneumonia readmission rate, isn't it? So it's very important. Accountable care organizations know this. Bundled payment teams know this. A lot of savvy readmission reduction and care transition teams know this. But I want to make sure that we all start out with a complete understanding that our patients who go into post-acute care, they need us more, not less. And it's very counterintuitive, but once you see the data and you think about it, you say, yes, of course. These are high-risk patients from a variety of perspectives. Interestingly enough, although we classically worry most about the pneumonia patient being discharged to home, and of course there are many patients, as you can see here in the red column, of patients being discharged to home, the readmission rate among pneumonia patients discharged to home, again, a little counterintuitive, it's lower than average at 14%. Now that doesn't mean that we shouldn't worry and we shouldn't serve them better. It's just what the data shows us is the discharges to home are not as high risk as the discharges into post-acute care. Let's see, sorry, I had a couple more points. Well, you can, in the interest of time, I'll keep moving here. Now, this is not North Carolina data because this analysis is fairly tricky and cumbersome to do. But what we did in Massachusetts was we looked at all our patients in 2016, all of our inpatients in 2016, and we said, does this patient have any behavioral health comorbidity, yes or no? It could be anything from anxiety, depression, alcohol use, schizophrenia, bipolar. It was any of the behavioral health conditions. And we said, what is the readmission rate for all patients in the state who do or do not have a behavioral health condition? And what we found was very important, and I really recommend it to your consideration as you're working on pneumonia readmissions and readmissions in general. If any of your patients have any behavioral health condition, their readmission, they're in a group that has a 77% higher readmission rate. So again, not specific to pneumonia, but we can, all of the clinicians on the line will readily recognize that yes, this makes sense once we think about readmission risk and the relationship with behavioral health comorbidities. Okay, a couple more data slides. This is getting into now thinking about your hospital. So I would recommend that you think about the prior data analysis. Do you want to replicate that for your own hospital? Can you take the insights from this statewide analysis and use it? Now we have a couple slides that represent all 106 data points that we have in the database, okay? So this is the range of pneumonia readmission rates by hospital across the 106 hospitals. And of course, you can tell at the extremes they're going to be, I looked at the data table. These are very small hospitals with highly variable numerators and denominators. So don't worry about the extremes necessarily, but we can see even in the 80% middle, there is a big range from a bunch of hospitals have pneumonia readmission rates hovering in the 10 to 15% range. And then we have a handful of hospitals with pneumonia readmission rates above 16%. The red line is that statewide average of 16% for pneumonia readmission rates. So when we talk about why this is so helpful is wherever we find variation, we can then look within our cohort to see, well, who are all these hospitals with pneumonia readmission down around 10, 12%? Because if you're a hospital with a pneumonia readmission rate in excess of 16%, it's not just that your patients are always sicker or more rural or more urban or more frequently Medicaid or more frequently Medicare, you know, or any of the hypotheses that we might test. It's really helpful in a collaborative like this to look at the range and start to identify who is doing well with regard to this in our cohort and what can we learn from them. So that's very helpful information. These two cuts of the data are, again, very tactical and practical ways of thinking about how are we going to go about attacking and knocking out, I should say, pneumonia readmissions. And what I noticed, what you see here is a frequency plot by hospital of the number of pneumonia discharges each hospital has per year in 2016, and the number of pneumonia readmissions each hospital had per year for all 106 hospitals. And of course, you can see on this first table on the left-hand side that we've got about 40 hospitals that have less than 100 pneumonia discharges a year. But we've got kind of a majority here in the middle with 100 to 400 pneumonia discharges a year. Why am I talking about this? Well, whenever I see a number like 100 to 400 discharges per year, I automatically divide it by 365 days in a year. And I say to myself, how many pneumonia discharges do these hospitals have per day? Is it 1 or is it 100, right? And no hospital in North Carolina, of course not 100, but no hospital in North Carolina has so many pneumonia discharges per day that we couldn't enhance care for each and every single one of them. And that's what this table can show us in general. And of course, you're going to want to know the answer for each of your hospitals or your hospital that you're working in. So take the number of pneumonia discharges per year, look at the average number of pneumonia discharges you have per day, and it looks to me like many of the hospitals in North Carolina have about 1 pneumonia discharge per day. And that's really encouraging because we can do something better for 1 pneumonia patient per day that's leaving our hospital. So that's how I like to use that information. Okay, so to conclude this tour through North Carolina readmission data, and this is all based on Aspire Tool 1, which you no longer need to do for yourself because the Knockout Pneumonia team has done it for you, and it's based on Chapter 1 of the Aspire Guide. What we can see here from the insights from this data is that adult non-OB Medicaid patients have a very high pneumonia readmission rate, among the highest at 18.3%, was it? We also know that we should probably be looking at the very least age over 45, but don't limit your work probably to over 65 because we would be missing those middle-aged adults who have that 16% pneumonia readmission rate, and that's a very important group of patients that probably need to be included in your work. We need to be mindful that there is a disparity by race, and that African American pneumonia patients have a 17.8% readmission rate, whereas Caucasian patients have a 15.5% pneumonia readmission rate. Remember that each and every single pneumonia patient discharged into post-acute care has a substantially higher readmission rate than our patients discharged to home. The difference is 14% versus 20 to 22%. Very important targeting. It has a lot of practical implications for who you work with, what services you deliver, and how you collaborate across the continuum. I would encourage us to be mindful that anytime we see a patient, including a pneumonia patient with a behavioral health comorbidity, they're going to be in a group of patients that have a much higher rate of readmission, and we should, again, develop strategies not just targeting the pneumonia, but managing the fact that the patient also is a whole person and they have a behavioral health condition, and that probably has implications for what kind of services and supports and linkages and follow-up we want to help put in place for them. And then finally, the last point that I was just going over with you is when we look at not only readmission rates, but readmission volume, getting all the way to the level of readmission, or excuse me, of daily volume of our target population, I'm very optimistic that you could set up programs and processes that would improve care for each and every one of your patients leaving your hospital with a pneumonia primary diagnosis in this case. So in the last few minutes, we are now going to say the best data analysis and the most thorough data analysis is not yet sufficient to design an effective strategy. We just got a lot of great information from this data, but we have not yet gone all the way to understanding the root causes of readmissions, and it's understanding the root causes of readmissions that opens up the most effective strategies to reduce readmissions for any given target population. So the approach that I encourage you to test for yourself, that many teams have found very helpful over the years, is to understand the story behind the story. Specifically, what happens to a person in a family, living wherever they live, going wherever they go, what happens to a person who ends up coming back to the hospital within 30 days? What happens that is not in the chart? That's the gap we need to fill. And that's where we want to get to the bedside and consistently start to interview our readmitted patients to understand the story behind the chief complaints. A lot of times we do readmission root cause analyses and we just use the chart. Index discharge chart review, readmission chart review, and we draw conclusions based on what's in the chart. If there's one thing I've learned, it's the gap that we need to focus on, not necessarily what was charted during the hospitalization of the index or the readmission. That's an important source of information to be sure, but it's missing this gap. So these are 3 of my readmitted patients that I met on the readmission. The first is they're not all pneumonia patients, but just to give you a smattering, they're all pneumonia or breathless related. 77-year-old woman discharged following sepsis who returned to the hospital 8 days later with shortness of breath. What happens, right? 61-year-old man who's already been hospitalized 8 times this year for shortness of breath comes back to the hospital 10 days later with shortness of breath. 45-year-old woman, long-term non-progressor of HIV. She was hospitalized for pneumonia. She was discharged to home, returned to the hospital 8 days later for cough. So since this is the pneumonia patient, I will expand. You'll see that I actually have a deep dive into the sepsis patient, but I'm going to expand on this pneumonia story and skip the sepsis one in the interest of time. So this 45-year-old woman, she had been diagnosed with HIV in her early 20s, and she had faithfully attended clinic every 3 months as required for years and years and years, and in fact, a decade, okay? Every 3 months in clinic, getting her blood work done. She was one of the lucky ones. She was a long-term non-progressor. And so she had, after about 13 years of going to clinic every 3 months, not needing any medicines, never getting sick, thankfully, she fell out of care. And it wasn't until she developed a fever and a cough and went to the emergency room, was diagnosed with pneumonia, was admitted, found to need to start on both antiretroviral meds and, of course, antibiotics for her pneumonia. And, you know, you look at her and she looks great, you know, and she's a young woman and she's looking put together, and she, you know, she looks young, which is what the mistake is here. And so the hospital team said, here's your list of meds, with not a really great appreciation that this was a list of, you know, 4 new medications in a woman who took 0 medications. And she was instructed to follow up with her PCP and her infectious disease doctor. Well, guess what? She didn't want to look like an idiot, so she didn't tell anyone. She doesn't have an HIV doctor, and she doesn't have a primary care doctor. And she got home with her bag of medicines, and she took them, okay? She understood them, she took them, but she wasn't about to start making phone calls with her stepdaughter in the house to start to look for an HIV doctor. So 8 days passed, she was taking her medications, she felt okay, but she had a nagging cough. She was just told she had AIDS, right? And pneumonia. So she had a very simple question. I'm taking my medicines. Should I be better now? Should this cough had gone away by now? She didn't have a doctor to call. She didn't have a nurse triage line to call. So she came back to the emergency room. Because her chart said new AIDS, right? She was expeditiously readmitted upstairs, even though she didn't have a fever, she didn't have hypoxia, she didn't have, you know, a white count. And it wasn't until the readmission event already occurred and the team talked to her more in depth the next day that we realized she actually is not feeling sick. She's actually not unstable. She just had a question, should she still be coughing? Which many of you will recognize, a cough for 10 to 14 days is not out of the realm of normal in recovery phase. So that's a great example of a chart review actually might have thrown us off, whereas getting to the patient and making sure we understand what exactly is the nature of your concern, what exactly are you back here for, we now understand that this was really about appointments. And when we said and navigation more broadly, we said, what would have helped to have avoided you needing to come back to the hospital? And honest to goodness, she's never read Project Red. She doesn't know anything about Project Boost. She doesn't know about the pneumonia knockout campaign. She literally said, it would have really helped if you had made a follow-up appointment with me with a new doctor. So not all pneumonia readmissions are the most complicated readmissions to avoid is part of the message here. So in the interest of time, this is kind of a deep dive that you see me going through in terms of a sepsis readmission interview. This is a little excerpt from a series of readmission interviews that a colleague of mine did in the emergency room. And it's not so much about the ED bounce back patient that I want you to think about, it's about their conclusions, which I think resonates across readmissions and across pneumonia and other types of readmissions. The authors found that after they interviewed these 60 patients who were ED bounce backs, the primary reason for returning, fear and uncertainty. And the primary service or intervention that would have helped, more access to reassurance and advice. And I connect the dots between our 45-year-old woman with HIV and pneumonia and the findings of these emergency medicine researchers. I think that is exactly on point. So food for thought as you start to think about your interventions and what your patients really need. Oops. Here is, I'm going to give you 2 tools about conducting the readmission interview. Many of you will just know how to do this because you take a history all the time. This is just a part of the history of present illness is the way I think about it. But some people want to know, how do I discuss this? How do I open the discussion? So this is just a little paragraph, an interview script that you might want to look at and work with as you start to have these discussions and incorporate them into your assessments of your recently readmitted pneumonia patients. This is the tool that's a little bit more of a structured tool with a chart review, an interview of the patient or the caregiver, and an interview of the related provider, whether that's a home health nurse or a PCP or a skilled nursing facility staff member. It's kind of a 3-part interview tool that, again, many teams find this very helpful. The link to the full tool is here on the bottom of the slide. So coming out of this work, I'd like you to connect the dots and say, we know a lot about pneumonia, we know a lot about the data of pneumonia readmissions, but we want to move into the readmission interviews to understand what factors actually contribute to our patients coming back after discharge for pneumonia. And what I encourage you to do as you work on your pneumonia readmission work over the next month is to go back to those questions that I posed at the top of the hour to ask, what is your aim? What does your data show? Which patients should we be focusing on? And what services should we thus deliver? Think about this. I noticed that most teams start in the reverse order. Most teams say, we're going to start with MedRec. We're going to start with post-discharge phone calls. We're going to start with making appointments within 3 days. I encourage you, all those things are not bad, but I encourage you to work the questions through in this order to really understand who are your readmitted pneumonia patients, what does your data show, what do your root causes show, and how should we address the root causes, and let that guide what services we should deliver in order to be most effective. So I'll conclude with a set of recommendations. Of course, these are always just recommendations, but I really recommend that you take the inspiration from today's data analysis and make sure you know your hospital's pneumonia readmission rate, the number of pneumonia discharges per day, and especially being mindful of pneumonia discharges by discharge disposition. I really encourage you to conduct readmission interviews for all of your pneumonia readmitted patients in March. That's my challenge to you. Collect and share the findings. email us here at the Knockout Pneumonia team. We would love to hear what you're learning, and we would love to share it forward in our next April webinar. And then start to connect the dots between data and root causes to think about the services and supports your pneumonia patients need in order to not have to come back to the hospital within 30 days. And most certainly come back to the April webinar and all future webinars with questions. We will set this up to be interactive. We will make sure that we can hear from you, and we really appreciate your time and attention today. So thanks so much for your commitment to reducing readmissions in general and readmissions for this very important group of pneumonia patients. Trish, I'll turn it over to you to close us out.
Thank you, Dr. Boutwell. What a very informative and robust webinar. We're about the remaining sessions, and just want to go ahead and prompt folks to go ahead and put the dates that they saw on the earlier slides. Those are the dates for the remaining webinars throughout 2018. Our next webinar is scheduled for April 5th from 2 to 3 p.m. You will see email marketing go out next week with a registration link, so that registration will be open and you can go ahead and register for that. And at the conclusion of this webinar in a moment, you will be prompted to take a brief survey. It's about 6 questions. We appreciate your feedback and input as we continue to plan and develop frameworks for continuing our webinar series. And again, if you have any questions as you take this information back and work with your teams on your pneumonia readmissions, feel free to reach out and contact us, and we are available for any questions moving forward. Thank you, everyone.
Trish,
have a great day.
Trish,
yes.
Trish. Hey,
yes.
Sorry, real quick. I'm sorry. I want to make sure that this gets answered by Dr. Boutwell. Amy asked, is the CMS definition for this population for readmissions? Amy is asking. So is this the CMS definition for this population for readmission?
No, Amy, and one thing that I do in my method, so this was not limited to Medicare, right? You noticed we were talking about, you know, Allpayer and Medicaid and whatever. So that's where I said at the very beginning, this is the very simple adult non-OB analysis of all patients discharged in North Carolina with a primary discharge diagnosis of pneumonia. We did not try to pull out for planned readmissions, and there's absolutely no risk adjustment here. But that's this is the type of analysis that I very much encourage you to use at the hospital level, because the way we improve readmissions for pneumonia or for anyone is to ask ourselves, who left our hospital and who came back for any reason, right? So this is a very quality improvement oriented, straightforward way of just saying who left the hospital and who came back, who left the hospital with pneumonia and who came back within 30 days. So thanks for the question on that.
You're welcome. Yes, I agree. Keep it simple and keep it real. So thank you, Dr. Boutwell, and thank you to everyone on the line for hanging on. This has been really great, and we'll be following up with you over the month, like Trish said, with prompts and reminders and collecting information for our next webinar to share. I hope you all have a wonderful afternoon. Thank you.
Thank you, everyone. We did have one last question that came in, and it is a general question. Do we share the slide presentation? And as always, we will be sharing the slides and the recording for the webinar. Those will be posted to the Pneumonia Knockout webpage, and we will send an email out when those have been posted. Thank you, everybody. That concludes today's webinar. You may now disconnect.